Yes, he does send his apologies, and there is currently a political issue in Macedonia involving a change of government, which I won't bore you with, but suffice to say I will probably be an even bigger hype man for the minister than he for himself. So I apologize if this comes across as a little bit overwrought. So, on the subject of e-health, we've heard about future technology, and I hope this isn't too backward when you hear about it, but Macedonia has a very interesting story in that over the last 4 years, Macedonia has deployed a totally integrated, centralized national healthcare e-health system. So in 2006, the idea of an e-health system was formed, and these were the goals, and almost none of them were achieved. Minister Todorov became minister in 2012 and has made a pretty brisk pace with all of those since then. The first one was to introduce a national system of electronic healthcare and data and establish an e-health directorate. So the system is called Moj Termin. I do apologize for the Cyrillic and all the rest, but it means basically my booking. The first and biggest crisis in Macedonia that the minister decided to deal with was waiting lists, which will be a familiar problem to everybody in Ireland. And in order to do this, basically, the idea formed of producing a totally centralized system where all patient records are stored that integrates the entire country. Attempting to change or revolutionize the current way hospitals would work or clinics work or the software they use is a huge endeavor, and the minister saw no point in doing this. This is where I got involved. So I'm from the company that built this called Sourcix, and you'll see me again later where I give you the kind of private angle on the public-private partnership, if you will, that built this in the country. But basically every healthcare provider and all of the state institutions were simply integrated under an overarching EHR and booking platform. And the idea was to federate rather than replace or revolutionize any of the existing healthcare systems. In fact, as this has progressed, many clinics have come wholly onto the platform and use it in place of other software, but, or not in place of, parallel with. So hospitals will always have a RIS, a PACS, various other pieces of software, but the fundamental integration and administration goes through the platform where previously it might have gone through 4 different miniature applications, an access database, paper. There were some local software vendors who have found other niches and so on. Basically 2 unique reforms that, as far as we know, have no parallel in the world, were enacted in fairly short order. The first one was to make, then they signed this into law, was to make the availability of all healthcare resources in the country publicly known. That includes patients, I mean people, citizens, but the most important one is for healthcare providers to be aware of these. And the second was to integrate the booking. So there is integration around the world, but as far as I know, no one else has done this on a national level where if something happens in one doctor's office, it's known about everywhere that it's relevant. For privacy reasons, it's not known about everywhere. But for example, if a GP refers a patient to a specialist, that specialist can now see the patient's record up until the point of referral so that they can provide adequate care. The core concept here is a single source of truth. Everything that's happened in the healthcare system lives in one place. And if anything needs to be looked up or accessed, or if anybody needs information, it can be found there. The first was to implement the booking system, hence that name, Moj Termin, and immediately attempt to deal with waiting lists. So Macedonia had huge and untenable waiting lists when the system implementation began, and within 6 months, there were no waiting lists. There's no list of people waiting for outpatient care. There is, of course, a surgical list, but outpatient care or time for admission for an inpatient slot, these have been effectively abolished simply by connecting the dots and integrating the system together. Referrals go electronically. Prescriptions now go electronically. So a patient who is prescribed something does not take any paper with them. They go to a pharmacy. E-prescriptions are more common now, but analyzing the data, the accessibility of data about what prescriptions patients were given and when is now fully integrated. So if a specialist has been referred a patient, they can find out what that patient went through before getting to them. There is more than 70 software vendors in the country have been integrated into the platform. As I said, the idea was not to replace, it was to connect. So in 2016, a few more programs were enacted. One is a national immunization register, because the general paucity of immunization records and relying on people to keep pieces of paper was definitely not working. And there is a mammography screening program that was enacted. So there is now a centralized system that automatically books into basically low periods people in for care, asks them if they can make the appointment, rebooks it if they can't, and little by little, there's a sort of a mammography and breast cancer management program at the state level. There's also a module to deal with diabetes. So there's a national register of diabetics, and this data is not widely accessible, but GPs will know if they have to deal with a diabetic, and there's a special module that ensures that the timing that they get insulin is managed, essentially so that insulin doesn't pile up and expire, and patients do receive prompt insulin at the right time. So I will not read this list out to you, and I certainly hope the minister wasn't planning to do so, but a huge amount of functionality that was previously administered by lots of phone calls and paper has been entirely absorbed into the system and is now wholly automated. I've mentioned some of the big ones like diabetes and the immunization register, and the reporting was also a big one because there was a public perception that Macedonian healthcare is dreadful, and the perception is not wholly inaccurate. I'm 90% sure the minister would not have told you that. However, I can tell you that you get it much, much quicker than many countries in Europe because of the existence of this electronic system. As the integration went through, the system was connected to the insurance fund so that it was known what money needed to be paid out to which institutions when. And the 70 vendors listed earlier are the primary vendors. Since then, another 20 have come on board. You must excuse me for any discrepancies in the numbers. This came from the ministry. I'm just telling you the story. But the idea was to enable direct integration, so the ministry can push information to some systems. Others fetch from the ministry, and sometimes it goes two ways. There are more than 3,500 healthcare institutions in Macedonia. So actually, I'll summarize this for you. The Macedonian healthcare system is about half the size of Ireland, and the population is about half the size of Ireland's. The key point here is that there are all the elements of the bureaucracy that came before and the relevant access rights and crucially privacy laws were implemented automatically through the system. So what people see and what they can do entirely fits the appropriate workflow that predates the system. So there was no change to the way people did business, if you will, or delivered healthcare. Business as usual was the order of the day. But just by connecting those dots, there's been a huge performance increase in the system. So I'll talk a little bit about that impact now. Firstly, there are no doctors, clinicians, or apparatuses that are inaccessible to GPs and specialists to book, and for members of the public to view. The maximum time that people are generally allowed to wait for healthcare is a month, unless a special circumstance exists. So if a patient wants a very specific doctor, they can attempt to demand this, but if that doctor is never going to have time free, they've been encouraged by their GP to select a more recent appointment. And this has been part of the way that the waiting lists were abolished. Particular doctors may have been piled up, not because they're particularly well known or have the best reputation, but GPs knew their name and that's kind of how it went. Once the system went in, this was abolished very, very quickly. The most important things here are the ability to implement reforms through the system that ensure an improvement in healthcare. So one of the first ones was that all occasions of service must be tagged with an ICD-10 code. This enables analysis to be done later on, firstly, whether the diagnosis was effective. So was it changed later and did that make sense? But secondly, where is care going and why? What diseases cause the greatest financial impact on the system? Where are doctors sending patients for particular diseases? Do things need to be reallocated? So the minister put in a number of programs, and I don't know if he planned to tell you about these, but I think they're one of the best stories that the country has produced as part of this system. It was very clear from some reports that were commissioned and some analysis that we did that cardiology coverage was not what it was thought to be. Particular rural areas had a much greater need for cardiologists than was expected. And the biggest problem was that Macedonians had no census for 15 years. So there was no effective block of stats that could say, there's an aging population here, probably more resources need to be allocated. So doctors were reshuffled, specialists were moved to do part of their week in one clinic and part of their week in another, and a program was developed so that, like a doctor swap. I won't try and translate the local expression for you, but basically hospitals would exchange specialists 2 or 3 days a week in order to manage their waiting times for care. And the impact was palpable. No rural areas now without care, sufficient care, whereas previously there were frequent complaints of patients never getting to see the specialist that they needed, and more importantly, just giving up. So when you've got a long waiting list, sometimes people who think they need and who think their need for care is non-essential just give up after a while, and they may have huge complications down the line. Anyone who's seen older patients come in and say, "Oh, I've had that ache for years." Now they have stage 4 cancer instead of stage 1 cancer, which can be promptly treated. Firstly, delivering a better outcome for the patient, and secondly, a much better outcome for the taxpayer who is not involved in the management of their care. The last point I will make here is, and this is a more or less a nascent thing, is the ability to respond quickly. So the ministry has live status reports of what's going on in the country. There's actually a dashboard I'll show you later that shows what is happening with care during the day, on any given day. If some particular infectious disease is appearing more and more, it's very easy to take quick action and find out what's happening. Obviously, there are certain miniature epidemics every winter, as is the case in much of Europe, but it's possible to do a far earlier detection and warning thanks to the existence of the system and the total integration therein. So I'll just throw some statistics out so you can see this is roughly half the size of Ireland. The country has 2 million people in it. In the last 4 years, almost all the records are electronic. There's basically 300,000 youngish folks who have not needed care for the last 4 years, so their record is not fully online. The names are in the system, but the records will be empty. There are 15,200 users around the ministry and its various institutions, and all the hospitals, clinics, doctors, and clinicians integrating, logging into the system to deliver care. So in some instances, they log directly in. In others, they simply use the software that their clinic already runs on, and it's all integrated in the back end. But we track essentially these authenticated tokens as we go through the system. In 2016, we had the busiest year. So one of the stories of the system that I'll go into in greater detail when we tell our private story in the afternoon. In 2014, Macedonia delivered about 7.5 occasions of service per person in that year. Now, that number is just over 10 occasions of service per person per year. There's been no additional investment in beds, in doctors, in resources or machinery. It is purely because patients get seen quicker and are willing to use the system more because they don't have to wait absurd lengths of time, that the level of service delivered and the utilization of the healthcare system has dramatically increased. On the secondary and tertiary level, it's more or less doubled. So this is the sort of story that gave a bit of hope to the ministry, which was facing a financial plan of rising care costs to attempt to deliver the same service. They're now delivering more service than was ever expected possible without a single increase in the budget. That frees up more money planned for improvements and enhancements, for more machinery down the line, or additional methods of care. So I won't dig too deeply in here, but there's statistics at the population level are now possible, and we saw some of those earlier from the UPMC. The country has slowly been doing more and more analysis, and I will present a little bit of that later on. But it's nothing that is unknown. What is unique about Macedonia's case is that you don't have to do a survey, compile records, or call people up. Someone at the ministry, and there's a little data bureau in the eHealth Directorate, is able to just write a query and in 1 hour find out exactly how many people and where they are have particular illnesses. Anonymity laws prevent, very small groups from being assessed. But the ministry is not concerned with one person in a mountain village who needs some care. Right now they're getting it thanks to the system. The ministry is concerned with where do funds need to be allocated, not just to improve care as the population ages and as things change in the country. Where can funds be allocated to effectively enact population-wide preventative measures? If not enough cardiologists are in the system, if people take a month to see a cardiologist and that increases the risk of a heart attack for all over 50s by 10%, a budget can be allocated to improve the accessibility of cardiologists, or train more cardiologists, or hire cardiologists from outside, and ultimately deliver superior care, not just because people are seen quicker, but because the outcome of that is a healthier patient and a healthier person. looking at when referrals are created per day indicates, this is not a big difference, but you can see that people who are sick on the weekend tend not to go on the weekend and they go on Monday instead. Some doctors may be willing to work on weekends, and this may basically reduce load on the system by spreading out demand. GPs, I don't know what they plan to do on the x-axis there. I'm going to skip that one. Again, please forgive me. I didn't write the presentation. I'm very familiar with the story because we have lived it as the vendor who delivered this over the last 4 years. This is a very interesting one. So, again, it's well known that aging populations have more hypertension, more diabetes. Macedonia has delicious food, but we do consume an awful lot of it, and that tends to show in the statistics. So the point is, if you look at these numbers, they are not rough. Excuse me. They are not rough. You know exactly how many of these cases happened and where. It's a query, and everything is in the system. It's possible to allocate very precise resources, improvements, reports. This is a very crude BI platform that we made for the minister some time ago. And basically by clicking on regions of Macedonia, it was clear where care needed to be redistributed. We have a much more impressive looking platform. I hope the minister won't mind my hijacking some of his slot to tell you, at the Sourcix stall, I believe it's stall 51. So we have we call it an epidemiology visualization tool. So there's a sort of a limited for presentation version where someone at the ministry can sit and just click on a data tool and find out exactly what is going on in the country on a given day in real time. And you almost get a feel for where patients are going and why, enabling changes, if necessary, to be enacted to improve the system. There's a live platform that the minister likes to show, and I understand we can't pull a browser up, but if you would like to see this blink, there is a live dashboard that looks like this, showing every single occasion of service in the whole country in real time. I took this screenshot this morning, so there's quite a lot more now. I think Macedonia sees about 15,000 referrals per day on a weekday. So please do come by and take a look. It's hopefully you'll be impressed. Last but not least, the story sort of expands locally in the Balkans because the progress in Macedonia was so tangible and internationally recognized that the Republic of Serbia basically took it up. They did put out a tender, but I don't think there were very many software vendors who could meet it and who could show a live implementation that had years of stable function. I don't know if the minister is even aware of this, but we ran the numbers a little while ago. The system has had 2 hours of unplanned outages in 3.5 years. That's 99.99% uptime. And I'm not aware of any hospital that has had so little outage, let alone something at a national level. Forgive me, we're very proud of the work we've done. So the Serbian tender we won in 2015 and the project commenced in 2016. So now there are 10 million people essentially on the same platform. The countries are not integrated for data privacy laws. There's a wall between them, but the fundamental architecture and the underlying platform is the same. Indications thus far are that Serbia is going to reap exactly the same benefits as Macedonia did. The system's been live for about 6 months, and you can explore some of those numbers as well at our stall. I'll talk about that later on this afternoon when I give our originally planned presentation. We've had some international interest for the system, particularly in Australia, in the state of Queensland and Tasmania, but as many of you know, progress at a national level of healthcare tends to be glacial. It's one of the most interesting things about the story is that it took only 12 months for the whole country to come on board. The minister used to hold sessions to basically to promote the system and its effective use, even as he was mandating that this occur with doctors in the country. And I sat in a room in 2013 as the early implementation was going in, where there was an incredibly hostile atmosphere of several hundred doctors in this amphitheater getting up and voicing complaint after complaint about what was going on. Part of the problem was the speed of the rollout. I mean, this took a lot of people by surprise. And part of the problem was that nobody wanted to change the way they worked. The shocking part of the story is that he continued to hold these sessions over the next few years. A year and a half later, I was in the same room with a similar panel of doctors, and most of them were reporting on their incredible satisfaction with the system. The moment doctors stopped having to fill in paperwork for no good reason, taking call after call because someone couldn't find some information and needed to know what happened with that patient last week, it's a mess. So we've heard a bit earlier today about integrated healthcare and e-health and telehealth. These are absolutely the right way to deliver healthcare, but there is also an administrative burden that must be released to enable these things to work to their full effectiveness. And at least in Macedonia, the integration and centralization of the healthcare system has led to a huge benefit. Now, the average waiting time for any kind of healthcare in the whole country is 1 day. It used to be up to 2 months for certain specialties, weeks for the others. You will be seen in 1 day for almost any kind of care you need. The best press we've got so far, and because few people know where Macedonia is, let alone have heard about the story, was from the Euro Health Consumer Index, where we were the rising star of the year in 2014 and have continued to score well. As I said, Macedonia still has problems delivering quality healthcare, but it delivers it very, very quickly. And there is absolutely no reason that this story could not be repeated in another country. Thank you very much. Please get in touch with us if you'd like any more information. And the minister will not be the minister for very much longer, but I'm sure he's happy to take a call in the meantime.